Thank you for having me. I've been tasked with speaking about Atrial Fibrillation Guideline update, and I have no disclosures. Atrial fibrillation affects about 50 million people worldwide and accounts for almost greater than $28 billion in healthcare spending at this point. It's incredibly common. It's a risk of developing atrial fibrillation in adults older than 40 is about 1 in 4, and that approaches about 40% of patients older than 80. It's associated with increased risks of death, stroke, dementia, MI, heart failure, chronic kidney disease, peripheral arterial disease. Risk factors for atrial fibrillation include advanced age, smoking, low physical activity, obesity, diabetes, hypertension, and having cardiovascular disease such as valvular heart disease, structural heart disease, and having chronic kidney disease, sleep apnea, all the things we know. In particular, I want to highlight the genetic markers. If you have a patient that's less than 45 years old and they're diagnosed with atrial fibrillation, it would be important to consider genetic testing in the very, very young patients who develop AFib, because it can be sometimes the first sign of a cardiomyopathy or an inheritable disease. So atrial fibrillation classification has shifted and now kind of mimics the heart failure progression. And patients who are at risk for atrial fibrillation are patients who possess modifiable and non-modifiable risk factors, such as obesity, low physical activity, sleep apnea, alcohol consumption. They have diabetes and hypertension. Genetics and aging are non-modifiable risk factors. There's a pre-atrial fibrillation cohort, which we see pretty frequently, and they have very frequent ectopy. You may see on event monitors and Holter monitors that they have very frequent SVT runs and a high PAC burden, but they don't have a formal AFib diagnosis. That's probably, someone that would be at high risk for progressing to atrial fibrillation. Patients who have been diagnosed with AFib we know this classification well. If they're paroxysmal in atrial fibrillation, that's someone that has episodes of AFib that last less than 7 days at a time. Persistent AFib is a term that we use when someone who's stayed in AFib for greater than 1 week. Someone with long-standing persistent atrial fibrillation is someone who's been in AFib for more than 1 year continuously. There's a new diagnosis in the guidelines a couple of years ago, and that's a successful AFib ablation. That's someone who underwent AFib ablation and has not had recurrence since that. And then, of course, there's permanent atrial fibrillation, which is simply a decision between the physician and the patient where we decide we're no longer going to attempt to get them out of AFib. So depending on the patient and what's going on, you may consider additional monitoring for AFib burden, if they need a redo ablation, and of course treat the symptoms and then leave the anticoagulation recommendations to Dr. Morris, who follows me. So rhythm monitoring tools for atrial fibrillation. We have a lot of tools at our disposal these days, and below you'll see a Cardia monitor, which is the first picture on the left, and that's on Amazon. There's a single lead Cardia for about $80, and the 6-lead one is $130. So they're very accessible to patients. An Apple Watch has been validated in the Apple Heart study, and it's got a great algorithm for picking up atrial fibrillation. Patients have to enable AFib monitoring if they've been diagnosed with AFib, or at least turn on the irregular rhythm monitoring, and those are options within most of the newer Apple Watches that they can use. And if you take anything away from this talk today, I think that it would be, when we read event monitors and Holter monitors, I see an indication for a stroke pretty frequently, or TIA. And a 2-week or a 30-day monitor is not sufficient to rule out atrial fibrillation. So if you get a 2-week monitor or a 30-day monitor back in a patient that had a thromboembolic event previously and it doesn't have AFib on that monitor, it's probably not long enough duration to prove that they don't have AFib. So I think that would be an indication for referral to EP for consideration of a loop recorder monitor, and at least a discussion about it with the patient if they're high risk for atrial fibrillation and they have other risk factors. And the loop recorder is the image on the right. It's a very quick procedure, and the battery lasts 3 to 5 years, depending on which manufacturer you use. And they're great for monitoring for atrial fibrillation in patients who've had thromboembolic events previously, with the goal of preventing future ones if you can diagnose AFib with it. With regard to primary prevention of atrial fibrillation, these are things that you all are doing already, which we greatly appreciate, and that's managing modifiable risk factors like hypertension, controlling diabetes, quitting smoking, reducing alcohol consumption, increasing physical activity. The recommendation is 210 minutes per week, which is about 30 minutes per day, and obesity. And with the GLP-1s and all these new medications the patients are requesting frequently, there have been some preliminary data on reducing atrial fibrillation, one with weight loss, but also with the assistance of these medications. So I appreciate your hard work on the denials and insurance approvals and titrations and lab monitoring and all the things. Much appreciated. So lifestyle risk factors that we can work on reducing, like I just mentioned, would be weight loss. So about 10% weight loss results in a significant decrease in atrial fibrillation burden and symptoms, and that's a huge thing that we can do for patients. That's level of 1 evidence. Also, activity and quitting smoking. It's a 2B recommendation to consider screening for sleep apnea because of the high prevalence in the population. So it's definitely worth a discussion about whether or not to send that patient for a sleep study. Reducing alcohol. Alcohol is one of the biggest triggers for AFib from dietary intake that we know of. Caffeine, a lot of patients come in and think that, oh, I need to stop drinking caffeine, but it's really not been associated with atrial fibrillation, but alcohol certainly has. So you can keep drinking coffee. Optimizing blood pressure and reducing lifestyle modification risk factors are other secondary risk prevention techniques that we should use. Also, the Electrophysiology Heart Rhythm Center, we have an atrial fibrillation clinic, and we're very happy to have this discussion with patients about all the other things that they can do to help reduce their AFib burden and symptoms going forward. So we have a pretty streamlined pathway to follow the AFib patients. So the question now becomes rate control versus rhythm control. And historically, the trials were, not strongly favoring one or the other, but some of the newer data favors rhythm control, and that the more recent trial targeted earlier intervention, which is probably why we saw a benefit with rhythm control. So in particular, rhythm control earlier in atrial fibrillation is more beneficial. Rather than waiting for them to fall into that persistent or long-standing persistent AFib classifications. The long-standing persistent AFibs are harder to maintain their rhythm. They've had a lot of remodeling happen in their atria, and it can be a lot harder disease to treat. So earlier is better. In particular, a patient with reduced ejection fraction, it would be favorable for at least a trial of normal rhythm to see if their cardiomyopathy is secondary to atrial fibrillation rhythm or rate. Even if the rate's controlled, just having that irregular rhythm can also contribute to cardiomyopathy. So it would be worth a trial of normal sinus rhythm if the patient doesn't have any contraindications for that. And pursuing rhythm control can help prevent AFib progressing into the long-standing persistent or permanent atrial fibrillation if we intervene earlier. With regard to that rhythm control, there's a few options. One would be rhythm control medications, and most of these would be medications that we follow pretty closely. Amiodarone, sotalol. Sotalol and dofetilide, of course, are a 3-day hospitalization to initiate those, but amiodarone is something that requires long-term monitoring to monitor for the side effects with the hepatotoxicity, thyroid toxicity, and potentially pulmonary fibrosis. So we see those patients every 6 months. And if you note any changes in their labs, then please let us know so we can have a discussion about stopping amiodarone and pursuing ablation, or where to go from there. So in patients with heart failure, like we spoke about, in particular reduced ejection fraction, AFib catheter ablation has a high level of evidence to proceed with ablation for those patients. Also pretty high level of evidence for patients with preserved ejection fraction, just patients who are symptomatic in AFib, and then after doing the ablation, of course, they need long-term surveillance. So that we show that their ejection fraction has recovered, and that if they develop AFib recurrence in the future, if they need a second ablation or where to go from there. If the patient's not a good candidate for rhythm control, then we're kind of committed to rate control, and the goal for rate control should be less than 100, 110 beats per minute atrial fibrillation rate. Of course, beta blocker, calcium channel blocker, digoxin, potentially amiodarone for rhythm control patients to keep the rate from being too fast and causing cardiomyopathy. And that's a shared decision-making conversation between the patient if they're a candidate for rate or rhythm control. If they have a lot of comorbidities, and depending on the clinical presentation. And I will say, like, pretty frequently we see patients who come in atrial fibrillation and they say, oh, I feel fine. I don't have any symptoms in AFib. And if you prompt them, like push them pretty hard, they have no symptoms in AFib. But if you say, to have a discussion that potentially you do and you just didn't notice it, and go forward with a trial of rhythm control, I'd say greater than 90% of the time the patients come back and say, man, I feel a heck of a lot better in normal rhythm. I didn't even know. So it's just something that's kind of subtly creeps up on people, and it's worth at least a conversation of trial of rhythm control to see if they have less shortness of breath, higher activity tolerance, and do better in normal rhythm. So this top left picture is a picture of the map that we make when we do ablations. So that's, you go in, up the groins, through the veins. That's the top left chamber, so that's the left atrium. The things sticking out in the sides are the pulmonary veins, and the left image is before, and the right image is after. So that's just a pulmonary vein antral isolation, PVAI. And we do a series of lesions around the right veins and around the left veins, which are the most common areas for AFib triggers, to isolate those veins. And this is a voltage map, by the way. So red is dead, purple is healthy. This is a relatively healthy atrium on the top left. In some patients, you go in and you make a map, and there's a lot of green and blue areas, and it's got patchy scar fibrosis, and those are patients who are probably more in the persistent realm or long-standing persistent. They have a lot more areas of AFib triggers, and the reason we have to go back and do a second ablation sometimes is either the veins have reconnected and our ablation lines didn't hold, and that usually happens after they leave the lab, because depending on the ablation modality you use, you may have isolated in the moment, and even after a waiting period it looks isolated, but occasionally they'll reconnect. But some patients will come back with AFib from the posterior wall, and that view we're looking at is of the back wall of the atrium. There's also anterior wall, and they can have flutters going around the mitral valve, or typical flutter on the right side, or a focal atrial tachycardia coming from really anywhere in the top chambers. So a redo ablation means we go back in, remap, try to figure out what's the problematic area for AFib at that point, and then target that to do an ablation there. And each ablation we do is a pretty tailored procedure to the patient. It's dependent upon the map that we make, on how much scar there is, what clinical arrhythmias we can induce during the procedure, and not all AFibs are the same. You don't really know what things are going to look like until you get in there, unless it's probably like a very early stage atrial fibrillation, then you can make a pretty good bet that things will look pretty healthy otherwise. The bottom left image is a picture of a right atrium, and so the patient had typical flutter. This is not a voltage map, but it's an activation map, and the color change shows timing of the cycle that goes counterclockwise around the tricuspid valve here. And this is the SVC up top and the IVC down below. And to do a cavo-tricuspid isthmus line or a CTI line, you simply do a line of ablation in the middle of this flutter, and it prevents the reentry electrical circuit from happening. And so you have to connect your line to things that are also electrically isolated, so we drag the line back from the valve. This cutout area is the tricuspid valve. So we draw a series of ablation lesions from the valve all the way back to the inferior vena cava. And so no electricity can get through here. This becomes scar, and that prevents this reentry loop from typical flutter. So the patients having recurrent issues with typical flutter, this is actually really easily treated with an ablation with a pretty high success rate. About 50% of patients who have typical flutter will go on to develop atrial fibrillation at some point. So important to monitor them for not flutter. It's possible they could have flutter again if there was breakthrough of the scar. That's pretty unlikely. It's greater than 90% success rate. But they could go on to develop atrial fibrillation. The yellow points up top are the His, which is close to the AV node, and we stay away from that area. But that's what a CTI ablation looks like for typical flutter. There's a few different modalities for ablation these days. Historically, we only had two. We had cryo, which is up top, and this is a balloon that gets very, very cold, and it freezes the veins, but essentially you would have a similar looking lesion set at the end of the ablation. And then we had radio frequency, which just looks kind of like the tip of like a pencil eraser, and you do a series of, each of these dots is a burn that we did with radio frequency. So we had cryo and radio frequency previously to do these lesion sets. But recently, there's a new AFib technology, and we have access to this here now. It's called pulsed field ablation. And the way pulsed field ablation works is it's electroporation. It creates these pores within the cells. And the goal of all of these techniques is to create lines of scar where electricity cannot cross through the scar. So these are all the new pulsed field ablation catheters, and it's been a pretty rapid change within electrophysiology, like huge change in the long term, and this is the future of AFib ablations in general, will be pulsed field ablation. And the reason is there's less collateral damage to surrounding tissues, and it's in general a more efficient technology. Previously, each little burn that you saw back here, each one of these burns would take a minimum of 4 seconds, but probably longer to get rid of electrical signals in that area. So it can take a long time if you're doing an extensive ablation. Pulsed field ablation is faster in general, and here we have our lovely Dr. Morris doing one of the first pulsed field ablations that we did. And I want to highlight, so let me go back. It's a quick blip, but this screen up here, if you look, see this green stuff happening up here? These are our two catheters we have in the heart, but all these little green signals are atrial fibrillation, and it's a continuous activation, continuous electricity within the heart on the green. And that, if you look at the beginning of this video, they're there in the blue as well, and then that bright white, that's when he goes on for ablation, and immediately those signals are gone. So it's a large area that you can target with pulsed field ablation, so it'll make us more efficient and more options to treat patients in the long run. So all those sharp signals are gone now after going on with pulsed field. So it's much more efficient technology in the long run, and hopefully will make ablation safer for patients. And this is what AI thinks what ablation will be. So as you can see, he has a magic wand, and he's gotten rid of the AFib with this. So now we have pulse field now, but I think in a few years, if we get the wand, we should be pretty good. So thank you.